Welcome back. In this lecture, I will talk about the lateral femoral cutaneous nerve or neuralgia parasitica. As usual, we'll get started with some anatomy. So the lateral femoral cutaneous nerve originate at the L2 and L4 as part of the lumbar plexus and then pass obliquely between the superficial and deep part of the psoas muscle. So this is the psoas muscle here, and you see the nerve going between these two layers, and it goes over the iliacus muscle. It then travels through an aponeuroticofascial tunnel, something hard to say, but this is what I mean by that. And it's basically it's part from the iliopubic tract to the inguinal ligament. Under the inguinal ligament or through a split in the most lateral part at the anterior superior iliac spine. As it approaches the anterior superior iliac spine, it courses under the deep circumflex iliac vessel. So if you notice here, this is the deep circumflex iliac vessel, and this is the lateral femoral cutaneous nerve. If you remember from my previous lecture, the deep circumflex iliac vessel is an important landmark when we do the fascia iliaca block. So then it goes through, enter the thigh. It may cross into the thigh anywhere between 6 centimeter medial to the anterior superior iliac spine and even over or 2 centimeter lateral to it. The lateral femoral cutaneous nerve may enter the thigh superficial to or within the sartorius muscle, which is another important landmark. Or it may cross over the iliac crest lateral and posterior to ACEs, where it's particularly susceptible to pressure from tight garment or belt. The nerve usually divides into two branches, a smaller posterior branch that innervate the greater trochanter area and a larger anterior branch which innervate the anterolateral thigh all the way down to the knee. So this is another view here, and here if you imagine you have the anterior superior iliac spine, here you have the pubis symphysis. So, and this is the inguinal ligament. So underneath here, there is two important facial layers. Again, if you remember from the first lecture, the first and most superficial is the fascia lata. So as you see, this is the fascia lata. So this is a nerve under the fascia lata. Then you have the fascia iliaca that enclose the iliacus muscle, which is another important landmark when we do femoral nerve. And this structure here within the femoral sheath, and that's the femoral branch of the genitofemoral nerve, just to give you an idea. So remember the iliacus muscle here. And here, one of the challenging part and very important thing to know about this nerve that there is a lot of anatomical variation in the course of this nerve. So it's sometimes it's really challenging to find the nerve. Usually, I would say 90% of the time, it's very easy, straightforward, easy block. But sometimes it's not easy to find the nerve. And this variation, it's important because some of them make the nerve more vulnerable for entrapment. So the most common form is when the lateral femoral cutaneous nerve cross the psoas muscle, then pass over the iliacus muscle. It is crossed by the deep circumflex iliac vessel. So this is a deep circumflex iliac vessel, and then it exits the pelvis, passing deep to the inguinal ligament. So that's the inguinal ligament. So it go underneath the inguinal ligament and medial to the anterior superior iliac spine, again, usually within 1 to 2 inches. That's the most common pattern. The second pattern, when the nerve pass through the inguinal ligament. The third one, when the nerve pass over the inguinal ligament. So imagine how superficial is that. Then the fourth one, when the nerve pass through the sartorius muscle. This is one of the most challenging one to find if you don't pay attention. And the fifth one, when the nerve pass over the aces. So you're spending your time searching here, going back and forth. If you don't start from the aces, you're gonna miss the nerve. Now, how the pain of the lateral femoral cutaneous present, I'm gonna talk about it. This is commonly referred as neuralgia parasitica. So to refresh our memory, there is no motor function for this nerve, and it gives sensation over the anterior and lateral thigh, as you see here. That's, of course, the anterior branch and the lateral aspect of the greater trochanter to mid-thigh region. So that's, if you think about the iliotibial band in that area. So clinical presentation, again, neuralgia parasitica, pain in that distribution. This is a common clinical issue, especially if you think about it. And then when you examine sometimes tenal sign, so tenal sign, so you feel the aces here, and you go about 1 to 2 inches, and you start to push with your fingers gently in that area and see if that reproduce the pain or the numbness. Now, common causes, as you see, blind femoral vessel cannulation, very common cause. See it after surgery. Patient come with this presentation. Now, it is the challenge with this. Sometimes it is often get misdiagnosed or confused with L2 or L3 disc disease. So usually, a lot of the times, then the patient go the route through, okay, this is coming from your spine, start to have a spine MRI, or the spine MRI showed something, and even to the point some patient end up with surgery. Another cause is prolonged delivery in lithotomy position, hip arthroplasty and arthroscopy, obesity of course, ascites, and pregnancy, all the same mechanism, which I'm going to show you a picture in a minute. And then tight clothing, such as sometimes, I see it in thin patient, and when you start to ask them, then that's a key one here. So history, as you see, is very important to catch this problem. There are other causes, less common, for example, psoas tumor here, right? And the lumbar disc herniation that often get confused. Iliac crest graft, sometimes we've seen patient after that, and you can go over the list, but diabetes, all these can be risk factors. Now here, this illustration show you the potential site of entrapment of the nerve. And of course, the most common site where the path of the nerve get interrupted. So that's a flat abdomen, right? No issues. You see the nerve going here, and then here you see a classic morbidly obese with the nerve distended in the abdomen. So you see how the nerve get stretched here and irritated. So this is the most common entrapment site. However, there are others, as you see, up to 15 potential entrapment site, mostly in that area at different structures. So, how we block this nerve, how we do a nerve block. So, it is very important to get yourself used to start from the anterior superior iliac spine. You know, this is whether you have a thin patient, obese patient, morbidly obese patient. This is very simple. You just feel it by your hand and then put your ultrasound over the ACEs. And I will show you a picture of that. And then start scanning from lateral to medial, because you remember there is anatomical variation. And if you don't start that way, you're going to spend a lot of time just fishing for that nerve. Then this is the lateral. You see the orientation here. And, you know, this is the fascia lata. This is the tensor fascia lata muscle. This is the sartorius muscle. Now, that's a classic picture here. Some people like to call it a cat eye or whatever eye. So that's like, you know, the pupil, and that's the eye. And again, this is lateral, so tensor fascia lata. And this is the rectus femoris. And you see here the sartorius. And again, the fascia lata here. Very classic. So you come from lateral to medial. I usually inject my medication and make sure it's spread around the nerve, up and down, like hydrodissection around the nerve. Now, here is less common, anatomical sites. So, for example, here the nerve is passing under the inguinal ligament. So, if you imagine that's the ligament here, you see under the inguinal ligament. In this picture here, you see the nerve. You see the nerve within the inguinal ligament. Here is another variability. So here you see the nerve within the sartorius muscle. So this is why it's important to go systematic when you look for this nerve. And here, after you inject the medication. Finally, get used to look at the size of the nerve. Get used to train your eyes, and it's not a bad idea to measure the circumference of the nerve. And if like this is exactly like what I'm saying, the cross sectional area. And if you are in doubt, you can compare it to the other side. That gives you a good idea whether you have a nerve irritation or not. Thank you. And the last part here, when we do the treatment. So usually the first and easiest step, I usually start with steroid injection. As I mentioned, I do some hydrodissection around the nerve. And you will be surprised in many cases that can do the trick, or at least give you a few months of relief. Again, if you go back to one of my lectures, it all depends on the severity of the pain and the duration of the pain. Another option, you can do radiofrequency neuromodulation, like pulse radiofrequency, cryotherapy reported. Peripheral nerve stimulator, we have a few successful cases. And of course, the last resort can be the surgical decompression. Thank you for watching.